Hello everyone. Today we are going to discuss on the practical presentation on aplastic anemia with pancytopenia. Myself, Mrs. Geetanjali Salimath, Assistant Professor, Department of Pharmacy Practice, KLA College of Pharmacy, Belgavi. I am going to discuss on this case. So here we have the case of aplastic anemia with pancytopenia. So now whenever we are going to discuss this, so initially I would like to have some learning objectives. By the end of the topic, learners will be able to know how to identify the type of anemia, clinical assessment of aplastic anemia through SO format, therapeutic assessment, patient counseling. So here patient demography, patient's age is 62 years old, she is a female patient who is housewife. Then we have to know that what is aplastic anemia and what is pancytopenia. Aplastic anemia is a condition that occurs when the body's bone marrow stops producing enough of new blood cells. It is known as disorder of the hematopoietic stem cell that results in a loss of blood cell precursors. So that is hypoplasia or it may be aplasia of bone marrow and cytopenias in two or more cell lines, that is red blood cells, white blood cells and or platelets. So to know the difference between aplastic anemia and pancytopenia, we have to understand that this is the condition or disorder of the bone marrow where the aplastic anemia will be differentiated with the pancytopenia in nature that the bone marrow, whenever the functioning is reduced, it is going to it will not have enough of new blood cells. Whereas in the pancytopenia, there is reduction in the red blood cells, white blood cells or platelets. So this is the difference between the two, and both are because of the dysfunctioning of the bone marrow. So here the treatment would include blood transfusion, antibiotics and immunosuppressants in case of the aplastic anemia, whereas in the pancytopenia, related blood cells which are deficient in nature that can be transfused. So to know that how we can identify the aplastic anemia or the pancytopenia, so we have the different tests like CBC, kidney profile, liver profile, electrolyte levels, vitamin B12 or folic acid levels to know that what type of the anemia, whether it is aplastic anemia or the pancytopenia. So in our case, it is aplastic anemia with pancytopenia. So always aplastic anemia will lead to pancytopenia, but it will not be the reverse order. Pancytopenia will not lead to aplastic anemia. So to confirm that, we have along with the other test, the bone marrow biopsy will help to confirm the diagnosis. So there will be other tests as I mentioned. They will be done to rule out that whether the person is having any other complications with the kidney or the liver or the electrolyte imbalance. So this is how we are going to differentiate between the two. So here this is a 62-year-old, sorry it is not male, female patient who was admitted with complaints of the fatigue since 3 days, unable to walk. So there is a decreased appetite since 3 days and melena. So these are like she is having weakness or she is feeling weak to walk. She is having the decreased appetite and she is having melena. So usually what happens whenever, because the blood contains the red blood cells which carry the oxygen. So patient will develop weakness or breathlessness due to anemia. So here because of the reduction in the red blood cells, there will be reduced hemoglobin and hemoglobin carries the oxygen. So whenever a patient is having deficiency of the oxygen, the patient will feel weakness or breathlessness. Decreased white blood cells cause the frequent infections and decreased platelets leads to easy bleeding from the gums, or you may feel like the patient will have the bruising. So there will be like dots on the skins or the patches which will be seen as the bruising. Patient may develop bleeding from the nose or rectum. If cancers cause pancytopenia, the patient develops enlarged liver or the spleen. So here, what is the history of present illness? The patient was apparently alright 3 days back. When she developed generalized weakness, it was insidious in onset and progressive in nature. She was getting tired while doing day-to-day activities, which already we discussed, and also she has reduced appetite and she has the black colored stools. So here the patient may be bleeding inside and the patient is having the black colored stools as internal bleeding. The past history, there was a history of blood transfusion, 2 pins PCV 4 months back. Personal history, there is nothing significant, and family history is also nothing significant. And as per her social history, the diet is mixed, habits like caffeine 3 to 4 times a day. The past medical history, there is no any other specific medication allergies or intolerance, no any immunization taken recently, no history of type 2 diabetes mellitus, hypertension, IHD, epilepsy or thyroid disorder. So here we are having this case of aplastic anemia with pancytopenia and there is no history of anything. So there may be chances that whether it is the genetic in nature or whether this is acquired in nature. So there may be like genetically it may be sometimes possible, but the genetic testing is not done here to confirm the same. The acquired aplastic anemia may be due to because of the exposure to some of the chemicals or where the working area where she has got been exposed to some chemicals, or there may be drug induced aplastic anemia will be there, or there may be some chances that the factors which have related to the aplastic anemia, as we discussed, like it may be the acquired aplastic anemia. So in this patient we will see in later that aplastic anemia with pancytopenia is identified, and next is the objective evidence. So here whenever we see the per abdomen, it is soft and non-tender, CNS conscious oriented, CBS S1 S2 murmur positive. So then respiratory and the respiratory rate, we can see air entry positive 18 per minute, respiratory rate is there. Then we have the pulse rate 84 beats per minute, it's little elevated. Blood pressure 110 by 70 mmHg. Pickle test pallor positive. So these are shown in the objective evidence. When the diagnostic test, as we discussed already, there is requirement of CBC complete cell count to be done. LFT and RFT have been done. ESG abdomen is done. Daily BP level checkups have been done. So these additional tests have been to rule out the other possibilities. So here we can see the investigational report. So above investigational reports will show that the hemoglobin, PCV, reticulocyte count, platelet count, RBC, MCV, MCH. So almost all we can see that the blood cell pattern or the CBC count is lower. So if we see the neutrophils and the lymphocytes, so there is a change in the normal, like compared to the normal levels, there is a change. So these tests like complete blood count and bone marrow biopsy can confirm the diagnosis. And to rule out the other like the liver dysfunction or the renal dysfunction, so we are having these tests which are like alkaline phosphatase is a bit lowered in this liver function test, otherwise all other parameters are normal. So tests like complete blood count, kidney function test, liver function test, electrolyte levels, vitamin B12 and folic acid levels are done to find the cause of pancytopenia. So these RFT or the renal these parameters which are checked here. So everything seems to be normal here. Then other lab investigations, so hematology was done. So on the different dates, so it was found that the patient is having pancytopenia with dimorphic anemia. So it is the microcytic, normocytic with normocytic hypochromic or microcytic hypochromic. So the different morphological or the microscopical whenever slides were done, examination was done, it was found that it is pancytopenia with dimorphic anemia. So here bone marrow biopsy was done. So it showed that hypoplastic bone marrow where only few cells of the bone marrow are functioning. So there are no other atypical cells or granulomas. So urine routine and microscopy was done here. There was no any observations were seen in this. Absolute eosinophil count was 50, vitamin B12 557, HIV is negative, HBS EG negative, ESG abdomen is like no any other complications were observed here. So this will indicates that the mainly there is complication with the bone marrow as the bone marrow biopsy is indicating towards a hypoplastic bone marrow. So these tests are done to confirm the diagnosis. In aplastic anemia, biopsy shows hypocellular bone marrow, that is, blood cells are less and they are replaced by fat. So this is the physical examination and the number of PCV transfusion and the RDP transfusion which are shown in these slides. And provisional diagnosis is aplastic anemia with pancytopenia. So this is the assessment which has been done. So this 62-year-old male patient was admitted in the ward with fatigue and pale skin, which are signs of anemia. Low hemoglobin, RBC and PCV shows hypochromic anemia. Decreased platelet count and other blood cells is due to pancytopenia. High MCV, MCH and RDW shows macrocytic anemia, which can be due to either vitamin B12 deficiency anemia or folic acid deficiency anemia, that is megaloblastic, or immune hemolytic aplastic anemia. So this is indicating whenever initially we are classifying the different types of the anemias. So we are usually classifying mainly the basic things you might have studied, like the hemoglobin or the MCV we are taking. So depending upon that, like we are seeing whether it is a microcytic, macrocytic or the normocytic. So here we can see that it is a dual anemia, or it can be aplastic anemia with pancytopenia. So normal level of vitamin B rule out the possibility of vitamin B12 deficiency. So here we had guessed that it may be either the vitamin B12 deficiency or the folic acid deficiency anemia, that is megaloblastic, or it may be immune hemolytic. So most of the tests and all, they are indicating towards the aplastic anemia. That is, there may be possibility of the immune hemolytic, or it may be the acquired aplastic anemia. Low ALP levels may be due to severe long-term vitamin and mineral deficiency. Anemia and macrocytosis increase the ESR levels, erythrocyte sedimentation rate. In anemia, the velocity of the upward flow of plasma is altered, so RBC aggregate fall faster. Macrocytic RBC with smaller surface to volume ratio also settles more easily. Low neutrophil count is due to aplastic anemia, where bone marrow has shut down production of all blood cells. Increased lymphocytes are the results of the immune response. Decreased reticulocyte count and hypoplastic bone marrow confirms hypoplastic or aplastic anemia, where stem cells are damaged due to immune attacking stem cells in bone marrow. So here, like, there is a possibility that our own cells or the autoimmune disorder has caused the bone marrow dysfunction. So the goals of therapy is to provide the better pharmacotherapy to get better health outcomes for the patient. So we have the list of the medications which have been given for the patient, that is multivitamin B complex, which includes the 8 vitamins to reduce chance of anemia, that is essential for normal functioning of blood cells, nerves or the muscles. Albendazole as the antiworm, this drug, multivitamin B complex to reduce chance of anemia. Then paracetamol, so here infusion is given to relieve mild to moderate pain. Ferrous ascorbate plus folic acid, treatment and prevention of iron and vitamin B9 deficiency. Again, the multivitamin is given in the form of the injection, that is like immediate to treat the anemia. Then ceftriaxone to treat and prevent bacterial infection. Then calcium supplement to treat the calcium deficiency. Omeprazole sodium to inhibit hydrogen potassium ATPase enzyme system. Then fluconazole to treat fungal infection. Ferrous sulfate as iron supplement. Piperacillin sodium plus tazobactam sodium to treat the serious and complicated bacterial infection. Then the discharge medication was given mainly as the ferrous ascorbate plus folic acid in the prevention from vitamin B9 and iron deficiency anemia to treat the iron deficiency anemia. Calcium supplement to compensate the deficiency of calcium. Then multivitamin, the nutritional supplement. Then the danazole, which helps in the increase the amount of certain protein in body's defense system. So patient planning, the patient-specific patient counseling was given. Random donor platelets are prepared from donated blood within 4 to 6 hours of collection by centrifugation, and it contains approximately 5.5, that is 10 raised to 10 platelets. So 1 unit of platelets RDP increases platelet count by approximately 5 into 10 raised to 9 liters, that is 5000 millimeter per cubic mm. So packed set red cell blood cells (PCV) are type of blood replacement products used for blood transfusion. So the patient is counseled that there is the transfusion of the PCV was given. So it is typically used in anemia, that is either causing symptoms or when hemoglobin is less, usually less than 7 to 8 gram per day. So in adults, 1 unit brings up hemoglobin levels by 1 gram per day. Assessment: patient has complaint of melena, which is passage of dark tarry pools containing decomposing blood, that is usually an indication of bleeding in upper part of digestive tract. So it was indicated by drop in hemoglobin and rise in urea creatinine ratio. Eat low fat dairy products, lean meat, fish, legumes such as lentils, drink plenty of water. Patient should take adequate rest and shouldn't move much or do work which needs more energy. So here the possible drug-drug interactions can be the injection mezol and injection tryptase. So combining these medications may reduce the effectiveness of piperacillin. The combination of calcium and ferrous sulfate, if they are taken together, they decrease the effectiveness of ferrous sulfate. The administration of ferrous sulfate should be separated at least 2 hours before the calcium carbonate intake. Drug-food interaction, there is possibility of calcium carbonate with food, like some foods which are rich in oxalic acid like spinach and phytic acid like whole grain should not be taken along with the calcium supplements. Then consider spacing calcium administration for at least 2 hours before consuming foods which are rich in oxalic acid or the phytic acid. Then albendazole with food. So take each dose of albendazole with meal. Taking in empty stomach may irritate the GIT and it reduces the effectiveness of the medication. Lifestyle modification: eating foods which are rich in nutrients as we discussed earlier, like iron, which increases body production of RBCs, like red meat, dark leafy veggies like spinach, then beans, legumes, then folic acid rich foods like cereals, beans, lentils, peas or nuts. Then foods which are rich in vitamin B12 like beef, fish, dairy products such as milk or cheese. Then foods which are rich in copper, like not directly the copper but which contain the copper which helps in RBC production, like shellfish, cherries, nuts. Then foods which are rich in vitamin A like dark leafy veggies, sweet potatoes, carrots, red peppers, etc. Thank you so much for listening to the presentation.